Thank you. Well, thank you, Dr. Hirschfeld, for your nice introduction. Is that okay? I'd also like to thank the Brain and Behavior Research Foundation for giving me the opportunity to share my research with you, all of you today. Dr. Hirschfeld mentioned my kind of career moving around the country. A few years ago, when I finished up my psychiatry residency at the Zucker Hillside Hospital, my residency director, training director told me that you need to stop moving around the world and stop moving around the country, just stay here. So I listened to his advice, and so here I am. I'm a psychiatrist. In my clinical practice, mostly I see patients with schizophrenia who experience a lot of psychotic symptoms like hallucinations, delusions, and paranoia and disorganized behavior. I'm part of the early treatment program at the Zucker Hillside Hospital. We specialize in treating young patients who had their first episode of psychosis or the recent onset of psychosis. And we offer medication management, psychotherapy, psychosocial, family support, as well as vocational help. Every day, I see patients getting better with treatment. However, the path to recovery tends to be a bumpy road. Many times, let me see if I can do this. Many times, patients do not respond to medication very well, and we have to switch medications and titrate down, titrate up, and to get the ultimate dose for a particular patient. Antipsychotic drug is the mainstay therapy for schizophrenia, and indeed has helped millions of people, millions of patients around the world to control their symptoms and help them to recover. However, only about 60 to 70% of patients respond well to antipsychotic medications. Up to 30 to 40% patients do not really respond to regular antipsychotic treatment. And as Mr. O'Neill has testified earlier this afternoon, that he has gone through multiple medication trials and finally got the right medication. So many patients stop medication due to either lack of efficacy or side effects. And many patients undergo multiple trials of medication before finally finding a right medication and right dose. Clinically, at this point, we don't have a good predictors to say which medication will be doing better for a particular patient. So a useful clinical predictor will be very important in guiding clinical medication decision-making. One useful tool is pharmacogenomics. Pharmacogenomics is basically using genetic information, DNA sequence information, to predict who's going to be able to respond to which medication better, with the maximum efficacy and minimal side effects. Pharmacogenomics has been successfully applied in other specialties of medicine, like a cancer treatment, and it is an emerging research field in treatment of mental disorders. The basic idea of pharmacogenomics is that DNA sequence codes for genes, and genes are translated into proteins. Variation in the DNA sequence can lead to alteration of gene function, which in turn will lead to change in protein and protein functions. All antipsychotic medications works by targeting neurotransmitters like dopamine, serotonin, as well as neurotransmitter receptors in the brain. So when there's a change in the DNA sequence, gene function will change, and it will potentially affect how medication works for patients. By studying the DNA sequence, DNA variation, we may be able to figure out which patient may respond better to a particular medication. So ultimately, by DNA profiling, we'll be able to classify patients into group of good response, no response, or patient with bad side effects. And for those cases, we definitely will need to avoid a particular medication. So, so ideally, we can use genomics to get the right dose of the right drug to the right patient at the right time. That's the ideal idea for pharmacogenomics, and that's what I've been working on in the past few years. One line of our research has been focusing on the DRD2 genetic variation and antipsychotic drug response. DRD2 is the dopamine D2 receptor gene, and the D2 receptor is the common site of action for all antipsychotic medications. About 9 years ago, our group at Zucker Hillside Hospital examined young patients with first episode psychosis in treatment either with risperidone or olanzapine. And they found that variations in the DRD2 gene for 2 SNPs is a single nucleotide polymorphism, which is a most commonly studied DNA variation. These 2 polymorphisms were associated with antipsychotic drug response. A few years later, when I got to Zucker Hillside Hospital from my psychiatry residency, I decided to pursue the same line of research. So I did a meta-analysis and pulling over 6 studies and over 700 patients looking at this particular DRD2 genetic variation, the negative 141C insertion deletion polymorphism. And lo and behold, we found that this polymorphism was associated with antipsychotic drug response. And both papers were published in Dr. Friedman's American Journal of Psychiatry. Okay, all right. The most recent breakthrough in psychiatric genetics is the finding of 108 genetic loci that are associated with increased schizophrenia risks. This is a very large study, about 50,000 patients and 50,000 control. And it's a collaboration of worldwide scientists, over 300 co-authors on that paper. Among these 108 genetic loci, one of them is on chromosome 11, and this is actually very close to the DRD2 gene. The top hit in these findings is this particular single nucleotide polymorphism over here, which is about 47 kilobytes from DRD2 gene. It's in the promoter region, probably will affect the gene expression of a DRD2. But if you look at the literature, nobody really knows what the function it has for this particular genetic variation. So we decided to look at this genetic variation in terms of antipsychotic drug response. We just finished up a large clinical trial for first episode psychosis. Patients were treated either by aripiprazole or risperidone. For 100 patients in the trial, we have the DNA data as well as outcome data. So we look at this genetic variation in DRD2 in association with clinical outcomes. It turns out that this polymorphism is associated with a reduction of positive symptoms. Positive symptoms are things like hallucinations, delusions, paranoia, and disorganized behavior, disorganized thinking. As you can see from this figure, most patients recover well with the treatment in 12 weeks. But patients who have both C alleles, 2 C alleles, recover more, in average about 10% more than the T allele carrier group. So this polymorphism is associated with antipsychotic drug response. It's also associated with side effect for patients on aripiprazole. This is a side effect called akathisia, which is a feeling of restlessness. It's very common in patients with aripiprazole treatment. This polymorphism is also associated with prolactin level elevation. Prolactin elevation is a common side effect of risperidone. So this study basically showed that perhaps we can use this polymorphism to predict who can respond better to medications, antipsychotic medications, and also they may have a differential side effect profile in terms of their genetic makeup. And this study was just published recently in the Schizophrenia Bulletin. In addition to studying patients with the first episode psychosis, we also study patients who do not respond well to regular antipsychotic medications. As I mentioned, many patients do not respond to regular antipsychotic medication. They have to go on to take a clozapine. Clozapine is, in some degree, is a really miracle drug for many patients. Many patients do not respond to 2, 3, 4, 5 different medications, but finally take a clozapine, and they're getting better. So we use clozapine therapy as a marker for treatment-refractory schizophrenia. A few years ago, we did a study looking at comparing patients who are stabilized on clozapine and patients stabilized on regular antipsychotic medications in terms of their genetic variation. And we found that the BDNF gene, this is a brain-derived neurotrophic factor, was predictive of a clozapine therapy. That study was, this finding was later replicated by a much larger study in Europe. But this study was cross-sectional. We don't really know how patients really respond to clozapine and what is the mechanism of clozapine treatment. So recently we started a new study for clozapine response. Unfortunately, we got funding from the Brain and Behavior Research Foundation. This is a longitudinal study. We use genomic, epigenomic, brain imaging biomarkers to predict the response to a clozapine therapy. We just started recruiting patients earlier this year, and so far we had 23 patients recruited. Just talk a little about other ongoing studies in our pharmacogenetic program at Zucker Hillside Hospital. We are running a randomized double-blind clinical trial to test whether pharmacogenetic testing can guide clinical treatment. We genotype a particular enzyme, a gene called the CYP2D6, which is a common enzyme to metabolize many antipsychotic medications like risperidone. And we genotype CYP2D6 at baseline, then we randomize patients into different treatment strategies of risperidone in patients with schizophrenia. Another randomized clinical trial we are doing right now is also for pharmacogenetic testing. This is basically a more of an outpatient study. We're trying to see whether we can apply pharmacogenetic testing to guide drug treatment to see if we can improve clinical outcome. In the future, we would like to combine multiple biomarkers. Obviously, any single gene or any single polymorphism probably will not be powerful enough to be clinically useful in terms of predicting drug response. So we'd like to combine multiple biomarkers and ultimately figure out the algorithm to see which patient will be doing better for any particular medication. And finally, I'd like to thank my mentors at Zucker Hillside Hospital, Dr. Anil Malhotra, Dr. Lenz, Dr. Robinson, and Dr. King, and of course the funding from National Institute of Mental Health and the Brain Behavioral Research Foundation. And finally, I'd like to acknowledge my patients who have participated in my research study so that we can really understand how we can help our patients in the future. Thank you.
Great, Bob. But first, is Rachel Epstein still here? Because we have your Metro card. You're going to have a hard time getting home. Okay, does anybody know her? No. Okay. Okay. Oh, all right, go ahead, Robert.
I think the first round of applause should go to the audience, which has been here for a lot of science, has absorbed it, has asked us all penetrating questions, and is staying for the young investigators, which is in the spirit of the Brain and Behavior Research Foundation. Dr. Zhang has quite a career. He has not only obtained his first funding from NARSAD, he has already amplified it with a grant from NIH. He showed you a bit of his science. I should say, looking at his list of publications, he's writing more papers a year than most people can read. In the meantime, he's trained himself as a psychiatrist here in the United States, duplicating his training in China, and he's accumulated a Ph.D. And I wonder if you sleep at night.
I take Ambien.
So we've heard a number of other more senior investigators refer to personalized medicine. And the hope has also come from the audience that someday a blood test would give you the genes. So as Mr. O'Neill described to us, Mr. Neal, I'm sorry, described to us, you wouldn't have to try every medication to hope for the best one. That's been a dream both of families and of the people who treat these families. It's so far an impossible dream way out in the future. But it is exciting to me that every once in a while you see someone who could make that dream a reality. And Dr. Zhang is that kind of person. So there are a number of things that genes do, and I was impressed in his presentation that he covered the basics of what they do. First of all, they determine how the brain develops and what the disease will look like. And that was things I covered earlier in my talk, and they've been echoed by most of the speakers today. But making sure that they're part of what we test for is very important. The second thing they do is they affect the particular system that's going to respond to a drug. So I think that Dr. Burke and Dr. Arnstein in particular, and also Dr. Castellanos, showed us different systems that respond during the treatment of illness. And just because a gene is involved in the illness itself doesn't mean it's involved in its treatment. It may be that what we're actually correcting is making a normal mechanism work better. And so that's a second set of genes. And then any drug that's given first passes into the stomach and then through the liver. And the liver takes its first crack. And so drug metabolism enzymes in the liver, which chew up most of the drug before it ever reaches the bloodstream in the brain, those genes are also important. There are very few researchers who have the temerity to look at all three at the same time. And there are very few researchers who not only have the temerity to look at them all at the same time, but also to apply them directly into the clinic. And Dr. Zhang has taken that on as his task. There are drug companies spending millions of dollars to make these tests. He got $100,000 from NARSAD, so, but my bet is on him. But I'd like to ask him how he's going to do it as my question. You're going to get a lot of information on a very well-selected group of patients. And how are you going to be able to integrate all that information so that we finally have something that you and I can use clinically?
Thank you. Well, I think that's a very good question in terms of how we can really utilize all the information that we have to guide clinical treatment.
Sorry, that's an old person's trick. He was trying to get rid of me.
I think at this point, pharmacogenetic testing is not up to clinical use yet. We really need to have more clinical evidence to show its efficacy, to show its cost effectiveness. In the future, again, I talk a little bit about combining multiple biomarkers together. One thing we can do is to look at gene-gene interaction. Obviously, the medications like risperidone, aripiprazole, or clozapine not just work on the dopamine D2 receptor. They work on multiple neurotransmitter systems in the brain. And we'll have to figure out how we can do that, looking at different gene, a combination of different genes and how they interact with each other. Another approach has become popular in the past 12 months. That is, use a so-called polygenic risk scores. In other words, for any particular person, you may carry multiple risk genes or risk alleles for a particular gene, and we can count up those genes together to see whether you are at a high risk of developing side effects or low risk of developing side effects, or higher probability of responding to a particular medication. So polygenic risk score is another way we're experimenting right now to see if we can become clinically useful.
I think you have a question.
Dr. Zhang,
Yes.
thank you very much for your presentation. I'm very interested in the DNA testing for getting the exact medication that would help the situation. But have you ever had a patient with DNA sequence in certain people who are resistant to the antipsychotic medications? And what can you do about that, if anything? And clozapine, I also have an adjunct. You still have to take the blood test once a week? Okay.
Yeah. I'll talk about the clozapine first. The FDA actually just changed the guideline for clozapine monitoring, but it's still, for the first 6 months, you have to do blood tests every week. And after 6 months, it's changed to every 2 weeks, and after 1 year, it's once a month. But they simplified the guideline in terms of which parameter you look at. Will make the patient life a little easier, make clinicians' life a little easier. But regarding the DNA sequence in terms of a drug response, again, I think that we have a lot of promising findings at this point, but we really need replication studies to show that the finding we have is real. I think multiple speakers today have mentioned the replication. You have to have multiple studies to look at the same thing, and we all find the same finding, then we can believe that that's real. One problem with a pharmacogenetic study is that most of the time we have a relatively small sample size because it's not easy to collect patient data for a longer period of time when at the same time collecting DNA information. But I think we're getting there, and hopefully in the future we can actually use a DNA sequence to predict which patient will respond to a particular medication.
Okay. Other questions for Dr. Zhang?
There's been work on the agranulocytosis gene, and it's not ready quite yet for the prime time. I just want to know your thoughts on that in terms of clozapine.
Right. One of the potential life-threatening side effects from clozapine is called agranulocytosis, which basically is a drop of a white blood cell count and puts you at risk for all sorts of infection. And that's why FDA mandated that the patient has to go through weekly blood tests if they are taking clozapine. There have been genetic studies looking at genetic basis of agranulocytosis. There are findings. I think the findings are real in the HLA region of the genome. The problem is that the sensitivity of those genetic tests is pretty low. I mean, it's only like 36%. The specificity is pretty good. In other words, if you test positive for that gene, it's very likely you're going to develop agranulocytosis if you take clozapine. But the sensitivity is not good enough. So at this point, every patient who are taking clozapine still have to have the blood test.
Great. Okay, I think we'll move on. Thank you very much, Dr. Zhang.
Congratulations.